Good afternoon, colleagues, and allow me to welcome the next speaker, Professor Yakale. She's Associate Professor and Head at SMU and George Macquarie Hospital. She has published many peer review articles. She was instrumental in the sort of for development of the curriculum and so forth, and she's served on various bodies, and as we all know, she's got vast teaching experience. Professor Nyakali. Is she in the house? Should we perhaps sweep it? Okay, so I think we'll proceed to the next speaker, Mrs. Padilla-Morales. She performed an internship in Barcelona related to radio-guided surgery. She then moved to San Francisco, where she sort of took an interest in patient care, rooted in medical innovation. She's presented at various SNMMI conferences, and she was recently elected as member of the SNMMI Technologist Leadership Academy. Mrs. Morales, please.
Good afternoon. I want to say how amazed I am to be here. It was about a year ago in Vancouver where I met colleagues from South Africa, and I'm so honored to be invited here. This is an incredible conference, and I'm so excited to be learning with my colleagues from around the world. This is my dream. So just thank you very, very much. Let's see if I can figure out how this thing works. Again, my name is Erika Padilla-Morales. My family's from Puerto Rico, so I'll say it like that, but I am still practicing how to say perra. So, today I want to talk about molecular breast imaging, and I'm positing it as a promising collaborator. I have nothing to declare, but I do want to offer an outline. I want to define breast cancer. I want to talk about how we image using mammography as a gold standard for detection. Then let's talk about the trouble with mammography. We'll talk about complementary imaging, and we're in nuclear medicine. We love to pair, right? We know hybrid imaging. So let's talk about how mammography can bring friends in order to detect cancer. Let's specifically talk about molecular breast imaging. We'll talk about some other potential collaborators. I'll share some thoughts about patient care, and then I'll offer more gratitude. At 14 years old, I found a lump in my left breast. My sister and I were swimming in the pool in summer, and she accidentally kicked me. And when I was showering that night, I found a lump. At 12 years old, I started reading about breast cancer and about self-examination, so I was in the habit. I told my mom, she checked, she said, "We're going to the doctor." And we went to the doctor, and the doctor confirmed, yes, that's a lump. But we needed to do some imaging. We would take an ultrasound, and depending on what that lump was, whether it was solid or if it was cyst-like, there would be surgery, or there would be a large needle stuck in my breast while the cyst was drained. At 14 years old, you can imagine that I was not excited to see a needle stuck in my breast watching liquid seep out of me. Thankfully, they found that the lump was solid. I went under, didn't feel a thing, but it was 2 centimeters. It was sent to pathology. Thankfully, it was benign. Grateful. I want to share also that breast cancer is personal to me. Breast cancer is how I got to nuclear medicine. I was a teacher before being a nuclear medicine technologist, and I was being laid off. That same semester, my aunt was going through her cancer care, and I was introduced to this incredible field. That was in 2011. So breast cancer is the most frequently diagnosed cancer in women. You see this map, and there's a lot of pink on there. In all of those countries, breast cancer is the #1 cancer in women. This is as of 2018. Some more global statistics. So in 2020, while some of us were busy doing other things, 2.3 million women were diagnosed with breast cancer. And breast cancer caused about 685,000 deaths globally. Again, we had the global pandemic, so we may not have been aware of those statistics. And as of the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the previous years. So it is the world's most prevalent cancer. In South Africa, breast cancer accounts for about 22.6% of all female cancers and about 16% of cancer deaths. Anyone with breast tissue is at some risk for breast cancer. And although rare, our male colleagues, about 1% of men will be diagnosed with breast cancer in their lifetime. To give some context, in the United States, about 1 in 8 women. So just know. There are 4 types of breast cancer. We have luminal A, which is about 50% of all breast cancers, luminal B, accounting for about 15%, HER2 positive, about 20%, and triple negative breast cancer, about 15%. Each one of these cancer types has its own pathology, its own biology. But luminal breast cancer is about 65% of all breast cancers. So there is a strong clinical need to develop new tools and improve assessment and optimize ER-positive breast cancer. But of course, I want to advocate that we need tools for all breast cancers. Clinical studies show that early detection methods increase survival rates by up to 5 years. So why do we image? We want to find tumors in the breast. We want to do appropriate surgical planning with lymph nodes. We want to look at the whole body and to see if there is evidence of metastatic disease. Mammography, we've been using this for about 50 years as the first line of detection in breast cancer. And at 40 years old, women are given that rite of passage where our breast tissue is turned into a pancake. And it's placed in between the petal, and we spend about a half hour with a technologist getting X-ray views. Our mammographies detect microcalcifications, masses, architectural distortion, and asymmetries. But we can't treat what we can't see. And mammography is ubiquitous, but it does not see well through dense breast tissue. Breast tissue exists along a spectrum, so you see through this illustration that it can be mostly fatty, then it starts getting scattered with fibroglandular tissue, and then heterogeneously dense and extremely dense. It is this last 2 categories that about 50% of patients fit in. So even though mammography is held as a gold standard, what are we missing? This graph illustrates the population distribution of dense breasts. You see from 40 to 49, that's the majority of breast tissue. But as we go out through women 85 plus, there's still a large majority who have dense breast tissue. Mammography is just simply not enough. The odds are high that a woman's first mammogram will have inconclusive results. So we need partner imaging. Women with dense breasts have a higher proportion of glandular breast tissue, which makes identifying breast cancer difficult. And patients with dense breasts have a 4 to 6% higher risk for developing breast cancer. So we have complementary images. We have friends. Ultrasound, CT, MRI. These are all anatomic imaging modes. And then I want to talk about molecular breast imaging, dedicated breast PET, and positron emission mammography. This is molecular imaging, more powerful, because then we know what these cancer cells are doing. So with ultrasound, we know that the ultrasound wave is transmitted to the tissue, and it can evaluate morphology, orientation, internal structures, and margins of lesions. Ultrasound and mammography work really well together to determine the nature, whether it's benign or malignant, of solid masses. About a 76% sensitivity and 84% specificity, but that depends on the skill of the technologist. With CT, we have contrast enhanced. It's one of the more sensitive imaging modalities. It plays a role in determining the extent of breast cancer to select the appropriate treatment. It's about 70 to 81% sensitivity and 79 to 90% specificity. Of course, we have to worry about contrast allergies. MRI, it takes advantage of the magnetic properties of hydrogen nuclei, proved protons, in breast tissue, and a small fraction of these photons are brought into alignment with a strong magnetic field within the MR scanner. The overall sensitivity and specificity of MRI for breast cancer is relatively high. In invasive ductal carcinoma, its sensitivity is almost 100%. So about a 75.2% sensitivity overall, 83 to 98.4 specificity. It's expensive, and it takes a long time. So let me introduce you to MBI, molecular breast imaging. Less pressure, similar views to mammography. So if you look at the mammography and MBI, these two machines are similarly constructed. So as a radiologist, you are introduced to images that are familiar to you. And a patient experience is similar, with less pressure. So essentially with molecular breast imaging, we are introducing sestamib, technetium-99 sestamib. We've been using it since 1979. It is well tolerated by patients. We inject a low dose. I did have to learn how to translate millicuries to megabecquerels. 8 to 20 millicuries, 300 to 740 megabecquerels. And we can image as soon as 5 minutes after we've injected the tracer. Imaging time is about half hour, 45 minutes. So, similar. The gamma camera images the tracer, and we get to see metabolically active tissue. The benefits: the tracer is well tolerated, it has good tumor uptake, similar views to mammography, and it's relatively inexpensive. It uses small semiconductor-based gamma cameras that provide high resolution and functional images of the breast. With the CZT-based MRI, the energy resolution is 3 to 4%. There's lower scatter, improved detection of sub-10 millimeter lesions, and there's a high sensitivity for detection of small breast lesions. Sensitivity is about 90%, and the specificity is about 82% for lesions less than 10 millimeters. Molecular breast imaging detected 2 to 3 times more cancers than mammography alone, and it provides high-resolution functional images of the breast. So let's do a little comparison. Along the top, we have mammography, tomosynthesis, which is 3D mammography, ultrasound, contrasted MRI, and MBI. So detecting cancer mammography, it's okay. We see at the further end that MRI and MBI, they're almost neck and neck with a higher detection rate. Imaging time, mammography, shorter. Ultrasound, a little bit longer. MRI is longer. MBI is about the same amount of time. As far as cost goes, mammography is cheap. Ultrasound's less cheap. MRI is expensive, and MBI is about as cheap as ultrasound. Radiation exposure. So we know that there are X-rays involved with mammography, and we know that there's radiation exposure with a tracer and an MBI. But that radiation exposure is minimal in comparison to the information that we can get for the patient. Nuclear medicine is no stranger to hybrid imaging. The combination of whole breast imaging, ultrasound, mammography has yielded a sensitivity of 72% versus 50% for mammography or ultrasound alone, according to the American College of Radiology and Imaging Network. Again, if we make friends with mammography, what can we do for our patients? So let's look at some images. In the pink box on the top, that is dense breast tissue on mammography. On the bottom, that's also mammography that has found a lesion. On the right, molecular breast imaging. So on the top, that's normal tissue. On the bottom, you can see the lesion more clearly than you can on the mammography. Again, in the pink box, we have dense breast tissue. That's a mammography. Molecular breast imaging, clearly showing the lesion. The third image, MRI, confirming the imaging that the molecular breast imaging showed. So I've told you about how great molecular breast imaging is, but where can we find it? In the United States, a country of 300 some odd million people, we have 32 centers that offer it across 19 states and the capital. I want to give you some context. There are more Americans that live closer to a Starbucks than we can find a molecular breast imaging center. The other thing that might be of concern for people are radiation exposure, okay? So I want to give a context of radiation exposure. Mammography and MBI actually lie within the annual radiation background. So for those who might be fearful of the radiation exposure, because I know that our breast cancer patients tend to have multiple imaging, that should be less of a concern. Our role is to educate. We detect, we image, we treat, we monitor. So let's offer some future options. I have the opportunity of working with the Mammy PET created by Oncovision. So this is a dedicated breast PET imaging machine. You'll see that little hole is where we put the breast tissue. So what I like about this imaging is that the breast tissue freely hangs, so we are not compressing the tissue, and we can better see. With our positron emission mammography, we have higher resolution, sensitivity of about 90%, specificity of about 87%. You see the imaging on the bottom, where we can clearly see the lesion in the breast. One thing about the reconstruction of these images, they haven't figured out how to flip it over 180 degrees yet, so that's something that I want to talk to the software engineers about. And then we have tracers like fluoroestadiol with a sensitivity of 84%, specificity of 98%. There's a lot of energy going into detecting breast cancer and helping to heal our patients. So for those patients with increased risk factors, mammography plus its friends are the best way for us to support our patients. Complementary imaging. We want to give the best advantage to our patients. We want to reduce breast cancer deaths. We want to treat patients sooner and improve patient outcomes. In summary, breast cancer remains the most commonly diagnosed cancer and the leading cause of cancer death among women worldwide. Mammography remains the gold standard for detection, but between 35 and 50% of patients have dense breasts, and patients with higher risk, patients have a higher risk for breast cancer. They need complementary imaging for appropriate diagnosis. Molecular breast imaging is a useful option. It offers functional imaging, is easily tolerated, and for radiologists, similar views acquired as with conventional mammography. Muchas gracias. Nkosi, Ngayabonga, Inkomo, Danka. Thank you, colleagues. Thank you for dedicating yourselves to the care of others. That's one thing that I think is really powerful about the nuclear medicine community, and that's a global community, and that's powerful. I want to thank the organizing committee for inviting me here. This is an incredible dream. I want to thank my team at UCSF for the Leadership Academy of SNMMI for inviting me to be more of a technologist than I ever thought I could be. I want to acknowledge my school, the Kaiser Permanente School of Allied Health Sciences. I graduated in 2016 and became a nuclear medicine technologist. My family and my friends. Muchísimas gracias.
Well, allow us to thank you for your very passionate and personal talk on this extremely important subject. And I think the large bags go to the ladies first.